Hey everyone, welcome to today's lecture. Today's lecture is actually going to be given by Dr. Dushyant Sahani. He's the professor and chair of radiology department at UW Medicine, which is like one of the top medical schools in probably the top medical school in US. And Dr. Dushyant has a lot of expertise in radiology, medical imaging, case studies, understanding a lot about how radiology interfaces with cancer and other areas of medicine in general. And he's author of many papers in peer-reviewed conferences and journals, and he's also written books, including one recently. Um, and he's also an advocate of mental health. So that's like an extra thing I want to share about Dr. Dushyant. So very excited to have him share with us some real insights and case studies in the space of medical imaging, cancer, radiology, etc. So Dr. Dushyant, over to you.
Thank you. Good to see you all. I'm Dushyant Sahani, and if you are surprised to see me here in an AI talk, that's exactly how I'm thinking about myself to speak to engineering students. Let me start with a disclosure. Every healthcare is all about human stories. Now, first of all, I'm a recovering Bostonian. And so, those who have not lived in Boston, you know that it's a loaded phrase. It comes with a different types of philosophy and attitude. Um, and people who live in Boston, their epicenter is within the few mile radius of Cambridge area. So, having said that, uh, let me show you a picture. Now, the person 2 year left is my 6 year older sibling. This is in like late 70s when we were vacationing in a beach town. Now, unfortunately, when my sibling was about 12-year old, he was diagnosed with chronic kidney disease. And after his long struggle in surgeries and dialysis, we lost him. And that was my first exposure to what healthcare means. Healthcare is a personal story for me, and these are personal stories for many in the communities. And one of the reflection I had was during this time was what families go through, what patients go through when they have a healthcare challenge. But also, if he had access earlier to care, his problem was completely curable, but was not diagnosed early, so it was diagnosed late. And this is not uncommon that many in the communities don't get access to good healthcare. So I think one of our priority is providing access to a good quality healthcare, especially to those who are vulnerable population. We have learned about that during COVID, how traumatic COVID experience has been for many. Then we look at our other responsibilities. These curves are not to scare you, but you can look at the growth in our spending on healthcare. And if you can see that by 2040, we will be spending more than 8% of our GDP on healthcare. Right now, we are close to 6%. And that means trillions of dollars which can be spent for education. It can be helped to build communities. It can be for many social programs which are so important. So more we spend on healthcare, we take it from elsewhere because you have a limited pot of money that can be applied for so many other priorities. Now, this is again should not to scare you. One way you can look at it is in a gratified way of how much we spend per capita compared to rest of the world. If you look at other advanced nation, we are the second is Germany. We are twice healthcare dollar spending per capita. Now, you might think if you're spending more, you should get a better quality or better health outcomes, but that is not true. Actually, our health outcomes are inferior to many of these countries that are listed here. Third point I want to make is uh, healthcare has to be optimized, it has to be convenient, it should be customized to individual risks and other factors, and you're looking at the social and economic factors. So one has to, when designing healthcare, you need to look at the whether it access is easier and if can be designed around patients and family needs. Now, another problem that we are seeing right now in healthcare, which has been actually been triggered through COVID pandemic, we are seeing a major workforce shortages. Not only physician, nursing, technologists, and this shortage is expected to grow. Now, the numbers here are just for radiologists, but you can imagine primary care physician, nursing, all by in next 10 plus years, we will have a major problem with healthcare coverage. And there are many factors, some of those being increased in aging population, a lot of needs on healthcare, chronic conditions, people are living longer. There is a lot of innovation on the treatment side, and a lot of this requires additional attention. A third thing I would say is during pandemic, there has been tremendous resignation. People have given or reduced their time due to many factors. And so that is an important consideration as we are designing healthcare. Physician burnout is a huge problem. Based on a recent survey, more than 50% of physicians and nurses report burnout. Now, what does burnout mean? Burnout means different things for different people, but in general, when healthcare providers, if they are not well engaged, if they don't see gratification or fulfillment from their job, they don't see purpose and feel exhausted all the time, that is burnout. Now, why that is important? Now, if you look at healthcare, uh, healthcare has thrived on optimism. Most of the innovation has happened due to the purpose and intrinsic drive to make a difference. That's what it's healthcare about. If go back and look at many innovations like Lennox, who introduced stethoscope. Lennox was he discovered stethoscope to diagnose TB. He wanted to understand the cavity through a easier way. This is before X-rays and all, but he died from TB. He didn't care. There are many such examples where scientists, physicians, they made a lot of sacrifices because of that purpose. Now, if you lose that purpose, if there is more cynicism, physicians will not be as involved in care delivery. That connection with patient will be lost, and that is a critical element we need to keep in mind. So, having said that, from my perspective, I would say healthcare is or medicine has been one of the best human endeavor. Humans have made many discoveries. We have been to space, many things we have done, discovered computers, machines, but healthcare has been the best human endeavor. But all healthcare is also a journey of data. So when we started initially, there was limited data. You look at pulse, you look at temp, maybe a blood test. That was it. But now data is too much. That is compounding the physician burnout issue. So we certainly need a better way to manage data. And these are some of the areas that I'm going to touch on where AI can make a difference. AI is not everything. AI will not take care of the emotional connection we need to have with our patient, but it can augment physician's role through some making things easier. So early detection, decision is assistant triage, and I will share with you with few case examples how this is impacting us. Treatment selection, as you can imagine, there are many treatments available for same diagnosis. For example, lung cancer, there are many drugs available. These are expensive drugs. We don't know which drug will work based on patient genetic makeup, the tumor makeup, and also other risk factors patient might have. So that treatment selection. Expanded access, as I mentioned, we many in our communities don't have access to good healthcare. Virtual care, we have seen this during pandemic, how much growth is been in telehealth, and it will continue to grow. And I think it has made one of the positives or silver lining during pandemic has been the growth in telehealth and adoption both by physicians as well as patient. Personal wellness and wearables is another area where there is a tremendous investments being made by startups. And finally, workflow optimization or operation, which really impact a physician productivity and also their wellness. Uh, so, so let's take first example, and I'm going to drive this point home through radiology because that's the space very familiar to me. So let's start with acute care. Now, what happens in acute care? These are the three emergency departments in the University of Washington Health System. We have the Harborview Medical Center, which is the only level one trauma center for five WAMI states. So very busy. We have the Northwest Hospital and the Montlake campus where you are right close to. And you can see more than 100,000 patients visit ED collectively between these three emergency departments. Close to 60% of patients need imaging. And of those, 40% need high-end imaging. That means cross-sectional work like CT scans, MRIs, and ultrasonography exams. And 20% of hospital admissions come through ED. Now, why that data is important? Because when you look at the ED volume, what you notice is there are certain hours in the day, and here, how do I show this? Okay. Here you will notice these are the hours of the day, which is this is at midnight, 1 a.m. and so on, and this is 11 p.m. And you can see these are the work RVUs, like number of exam each hourly presenting in the EDs and how it grows, and they belong to different specialities, different body parts. Why that is important? Because patients who come in ED are really need timely diagnosis. We need a better workflow or triage so we can give the right care at the right time to patient who needs the most. There is high complexity of care, so decision making is critical. For example, in a patient who has blocked one of the arteries to the brain, earlier we intervene and thrombolize, they might have recovery, otherwise they lose their neurons in the brain. So timeliness is critical. So here in this situation, in UW medicine, what we have introduced are these AI tools. Now, these are tools specific to make a diagnosis of a condition, even though there might be multiple findings in the body when patient come with a suspected condition, but also incidental findings. For example, a patient who is coming with trauma might have an incidental cancer. We don't just look for trauma. So given that there are so many things to look at and we need to give a timely diagnosis, there are these tools which are assisting us. So let's look at some of the common problems in the ED setting. For example, in the neuro area, intracranial hemorrhage and vessel occlusion is a diagnosis we need to know quickly. Likewise, cervical spine fracture, as you know, if the fracture is unstable, that can cause compression of the cord and lead to devastating consequences. Occlusion of certain vessel like pulmonary embolism, it needs to be thrombolized, otherwise patients have a bad outcome. Looking at incidental nodules, some of these nodules can turn into cancer. So when you are rushed, you might miss some of these tiny nodules. And also other critical findings, like if there is free air in the abdomen, which means a hollow viscus like a bowel has perforated. That can happen due to many reasons. One of them is penetrating trauma, but also if patient who have bowel ischemia or had prior surgeries, their bowel can rupture and leads to free air. So these are some of the diagnoses we need to make quickly so that patient can get right treatment at the right time. So we have introduced these tools. How do they work? Is patient, CT scan, patient is scanned. There is this AI tool which sits there in the background, analyze all the exams, looks for abnormality, then prioritize those which are positive and sends out notifications. So it takes about 2 to 6 minutes to process each CT exam for these critical findings. So let me show you how does it work. We have tools. This is on the desktop. When as a radiologist, when I'm reading these exams, at the bottom there is a widget which just shows me if there is exam is positive or negative for the exams I have opened. For example, this is a brain CT scan. This patient doesn't have a hemorrhage. This is an example of a patient with a pulmonary embolism. And we can do both on the desktop, but also there are apps, so we can send a notification on the app. So how does it work? We have a prioritization notification of acute findings. This is a patient with hemorrhage. It this is a patient with hemorrhage positive, so it shows this, and alerts us. And so when I'm reading studies, I can see it. This is a positive. When it's negative for cervical spine fracture, so that makes it much easier to prioritize those cases. For this is the list of cases that might have positive findings. So I can quickly do a QC for the ED list if any of these exams have been reported or communicated to the physician, so that timely treatment can be done or not. So we are talking about thousands of patient data. This is in 30 days, about 8,000 exams, CT exams, which are processed using this tool. 10% of these exams are positive for different types of, indications like pulmonary embolisms and all these. So it makes the workflow much more desirable, much faster, and it is assisting us, because imagine in the ED you don't have all the expertise. It's ED is a melting pot where you don't know what is the next exam you're going to see. Is it a brain trauma? Is it a pulmonary embolism? Is it a vascular study? So you have to be quick on your feet to be able to diagnose those things, and these tools are assisting us in making those diagnoses. Now, this is one such example. I don't expect you to appreciate the finding, which was completely missed by radiologists, but the AI algorithm, which don't work on visual assessment, but based on structural changes. Here, there is subtle hemorrhage, which was completely missed. And in the hindsight, this was positive. And of course, we alerted the referring providers who had to change management for this patient. So again, very helpful. This is an example of a very small clot in a branch of left side pulmonary artery, which was missed by initial radiologist interpretation, but the tool alerted us and we could correct the report in timely fashion. So you can imagine overnight, when a trainee who's less experienced is dealing with all these complex cases, these tools come really handy in assisting them for making a diagnosis. Now, this is a work we published during my previous job in Boston. What we looked at is the deep convolutional network, neural network, assisting in kidney stone diagnosis. Now, kidney stones is a big problem. We see, and many patients recur. Some of the stones might obstruct the kidneys, and I think the small stones can be difficult to diagnose. And a patient who is coming with abdominal pain, there are many things you look for. One of those are kidney stones. So this was the AI algorithm showed us that any stone which is more than 3 millimeter size, which is the significant stone that one manage, the tool is accurate in more than 95% of the time. It can reliably show the kidney stone diagnosis. So that is the first one. I hope you got a point how in the acute care we are actually using it to triage patient for some of these important. Yeah.
The acute care that you mentioned, AI doesn't use the deep learning and computer vision technique.
Yeah. Yeah. And it real time process it. And it takes anywhere between 2 to 6 minutes to process each case. So, and it can process in a day a few hundred exams real time. So, and and it's all on the cloud. So, the processing is much, and it's also cost effective that way. The second area is personalized diagnosis, which I also call as integrated diagnosis, and I will tell you what that means, and also better risk assessment in patients. So let me share with you an example of a patient who has chronic liver disease. So cirrhosis is one condition which is commonly caused by hepatitis virus. Hepatitis C is the leading cause. Alcohol and many drugs and toxins, which are metabolized in the liver, they also create that risk of chronic condition where HCC, which is hepatocellular carcinoma, a malignant tumor, can be seen. Now, it's important to detect these tumors when they are small. So you can offer them a curative treatment, which is liver transplant. And as you know, that there is shortages of organs. So you need to be highly prescriptive who should get the transplant. For that, early detection is critical, and we use imaging. The tumor markers don't work well for diagnosis, so imaging is critical. And as we know that cancers rely on many factors. One is the patient factors. All livers are not same. If the patient has multiple other risk factors contributing to chronic liver disease, their risk of cancer is much higher and they might have a bad outcome. There are environmental factors. How is the background liver and what type of tumor biology, and overall what type of disease. So let's say if we see this lesion, typically radiology is not diagnostic. What radiology does is a probability rating. What is the probability that this lesion is malignant, and if it is malignant, is it hepatocellular carcinoma where we offer transplant? So that is based on many factors which are subjective. We look at how lesion appears, what is its size, how it is lighting up after contrast, how it behaves with the images. That is dependent on radiologist expertise, the scan quality, and other factors. But now, if we can take that information and now add other factors like, okay, what is patient sex, genetic makeup, other risk factors, and take into consideration things like what is happening in the liver, how bad is the fibrosis in the liver, are there other things like iron deposition, patient has other features like this, and what is patient's muscle mass, which is again a sign of overall health, and then come with a much better probability scoring that 96% hepatocellular carcinoma and 98% malignant lesion. So that is where the precision diagnosis or integrated diagnosis is moving, and there is a lot of excitement. A lot of startups are working. We are also working at UW in few cancers, and HCC is one of those cancer we are focusing on. Second is, on the images, there is a lot of high value data. Unfortunately, since diagnosis on images relies on subjective assessment, we use less than 1% of data for decision making. 99% of data is actually not even applied, but this data is extremely valuable. What does it mean? So let's say, for example, here in a patient can have many problems in the body. Let's say patient comes for appendicitis diagnosis. We look for, in a CT scan, there is no appendicitis. But what we can do is we can look at other organs. How is liver? Is liver bad? Does liver have fatty infiltration, which is a result of toxins or a bad diet? How is the muscle mass? How much is the visceral fat? What is the atherosclerosis content or quantity? What are the other factors like, is the bones weak? Because bones have a certain density. We can extract this information now and automate that to give a better risk prediction for cardiovascular event, diabetes, metabolic syndrome, risk of future fractures. So it creates an opportunity for more screening and future risk for the patient. So you can imagine with AI from the same data, we are adding value which didn't exist in the past. The potential consequences of this is we can do customized testing. Let's say an appendicitis patient who came to ED, even though there was no appendicitis diagnosis made, but we know this patient needs to have counseling or a consult with a hepatologist or an endocrine physician or a wellness physician because of other risk factors we see in this patient. So again, great opportunity. Also, we can extract data, more quantifiable data from tumor, not in terms of volume, but viability and heterogeneity in the tumor, which we know heterogeneity correlates with the aggressiveness or angiogenesis. This is a study that we participated in patients with pancreatic cancer. What we noticed is those patients who, after they received chemotherapy and radiation, patients who lose muscle mass on treatment, because we do imaging frequently before and after treatment, they have poor outcome. Whereas patients who gain muscle mass or they maintain their muscle mass, they tend to have higher likelihood of resectability. What that means is potentially we are missing metastasis, we are not seeing they exist, and that's why patient has higher metabolism and they are losing muscle mass. Now, this is not a isolated example with pancreatic cancer, which is a really horrible disease. It has very high mortality. But other conditions, patients who have lung cancer, patients who are going for transplant, patients who are getting dialysis, chronic kidney disease, name it. In these conditions, body composition like visceral fat, muscle mass, all this is a predictor of how well patient will do after a major treatment. So it's gaining a lot of popularity, and we have tools that can automate extraction of this data. So it's still not there yet because people are, we need to get more validation for this. The third is clinical decision support and recommendations. Now, why this is very, very important is because we see on images many findings. Incidentally, even patients with or without cancer, we see findings in different organs. And sometimes we don't know what to do about those findings. And this leads to unnecessary investigations, interventions, patient anxiety, extra cost, and it leads to misuse of some of the healthcare dollars. So it's critical that we have better handle and for with clinical decision support and recommendations. So let me show you a model that is emerging in the future. So for example, this patient has been scanned for suspicion of lung cancer because of chronic smoking history. On a CT scan, you can see on the right side there is a nodule. Now, not all spots or dots in the liver, lungs mean cancer. Some of those might be cancer, and even in patient with smoking history, we see dots all the time. Not every spot means cancer. So now let's say a radiologist is looking at this, and if the data is being analyzed in cloud, what based on the prior use cases with similar type of morphology, the findings can be first of all recognized automatically. You can, the radiologist will see annotation on those findings. Then based on the guidelines currently that exist for nodules, and looking at patient other risk factors, a lesion classification and recommendations can be automated. As you can see, it's a very organized report, with a template, a structured report with an image that goes. There is a radiologist interpretation which goes to EHR. A communication is sent to a referring physician with a structured recommendation, and we can also monitor if patient had those follow-up and recommendations or not. So it creates a very closed loop communication process by applying the AI tools that we are seeing a lot of hope and progress right now. Yeah. It's being tested out, especially in the lung nodule. There are companies who have approved tools. We are going to have this soon from a company called Riverrain. And what they do is precisely this. They recognize the finding, they classify the finding, and give structured recommendations. So like this, incidental findings in the brain, in the joints, in abdominal organs like kidneys, adrenals, liver, you can apply the same concept, and that standardized care delivery across the health system anywhere.
So this digital report that gets generated through the software, does it save time for an actual report that the radiologist finally signed off on?
I think it initially it might not save time, because it's few extra steps, but it is more accurate. Later, it will save more time and healthcare dollars. And as you get comfortable doing this, it saves time. For example, when we started with voice recognition, all our reports are through voice recognition. We don't type any reports. When we moved from transcription to voice recognition, initially it was pain because the system was learning. Over time, we've got far more efficient. Means our efficiency, increased almost 3 times that you can't imagine going back ever. So it's the process over time as you gain experience, and also the system learns you and your style of doing things, and you can customize some elements in the workflow. I think the workflow is the critical aspect here. It doesn't matter how accurate these tools are. If the workflow is seamless and integrated, it'll make it much easier. You look at this space, the imaging AI landscape is so promising. There are so many startups, more than 150 companies developing AI-based decision support tools. There are already over 100 FDA-approved products in 2022. A lot of money is being invested. So you can say there are real progress being made in the AI space on the diagnostic side. And I think the final element that I will touch on is on the workflow or imaging operation. Efficiency is key. Efficiency leads to improved access. It leads to more productivity and satisfaction. So currently, if you ask me, the new buzzword in healthcare is all about workflow and efficiency. That's the key thing, and a lot of interest in improving efficiency. Now, how can AI help us? Now, if you look at patient care coordination, it has many elements to it. Right from once a physician diagnoses a problem, wants to schedule, orders an exam, then we have to schedule the exam. There is an image acquisition piece to it. The data is processed and analyzed and interpreted. Then there is reporting and result communication. There is shared decision making, which is the consult with referring physician. This happens frequently in the healthcare setting. And then you have to look at outcomes, follow up, especially oncology or any of those incidental findings that I just touched on. Now, this is one such example where using AI, we look at our operation, imaging operation. These are various imaging tests. The CR means conventional radiography, CT is obvious, ultrasound, MRI, this is mammogram, then these are some other tests. So what we can look at is what is the utilization of these imaging tests and how much time does it take? You can get a big picture of what is the acquisition totally it's taking for various type of exam. For example, here the PET CT takes on an average more than 60 minutes, followed by MR is close to an hour. Now, how can you improve access if it takes so much per patient? Whereas CT here, you can see CT is just few minutes, like less than 15 minute slot. So this gives you an idea. If you want to get a better return on investment, look at the main barriers for care delivery will be MRI and PET CT studies. So from an operational standpoint, I know how I will prioritize my workflow, and that's an area where I'm going to focus, because rest all, I will have very low return on investment. Other areas are doing pretty well. So that's how, and I think we have a lot of dashboards. I'm not going to bore you, but the data is powerful. Data gives us idea where we need to make a change or improvement, or where we are doing well. And in radiology department, if you come there, you will see many dashboards we are using to look at our workflow, quality, safety, finances, and if we want to expand our services, a lot of this is helpful, and I think some of the AI work is being applied. Now, this is a picture of a 3 Tesla MRI. And has anyone gone through MRI exam ever? Okay. How much time did it take for MRI? 20 minutes? Where? Where did you get MRI? Oh, God. Yeah. Yeah. So anywhere like 30 to 45 minutes, and it takes a while to get an appointment. and these are expensive machines. You can't put a lot there is a lot of shielding that is required. The construction is takes a lot of time, effort, a lot of management. There are many quality safety measures one has to take care of. Every scanner has to be approved, whether it meets quality and safety standards, so huge expense. Now, there are new technology which is available. This is a portable MRI mainly for brain. We have it here in Harborview where we are using it for research. So you can do a brain MRI now with a small portable equipment which maybe costs less than $100,000 than, a few 3 or 4 million dollars. This scanner, you can actually take it to the patient and still provide high quality images. How it is that happening? AI is assisting. AI is taking that limited resolution data and creating high quality images because it has been trained. So you can imagine how it's helping. We have probably you have seen portable ultrasound probes which can be attached to the iPhone. You don't need a big machines anymore. This is a portable CT scanner. Every big health system has few of these because you take it to the ICU to look for if patient has a bleed or not. It's a lot of work to bring an ICU patient, neuro ICU patient down for a scanning. So you can take these scanners there and get a pretty high quality images. Not only that, now imaging is being installed in a trailer and we are taking these to the patient. As a matter of fact, we have few imaging equipments in a van to mammogram equipments. Very soon we will have a CT scanner in a trailer that we will take it into the community to improve healthcare access for lung cancer screening and other types of exams. So, this is a great example how innovation in technology and AI is enabling democratization of healthcare. Really exciting space. Of course, this will improve access and lower cost.
Good question on the ultrasound.
Yeah.
Is that doing an image enhancement? That the software that's doing an image enhancement in real time?
So it depends on which company. Like with this company, Butterfly, the images go to the cloud. They have a lot of AI tools on cloud for annotation, anatomic localization, and that's how it's
So
being
in
done.
real time, you get the
Yeah.
annotations back.
Yes. Yeah. In real time, you get, and actually, they are working on some enhancement to even assist in image guidance procedure. So, example, if place somewhere in Africa, the probe is cheaper. It's there. I think it comes to $1,000 or $1,500 compared to an ultrasound machine, which might cost anywhere between thirty to $100,000. So technology is now available, but expertise is lacking. So AI is being applied for diagnosis, but also for image guided procedures remotely. So that's a great example of how AI is
It
improving.
can help with standardization.
Absolutely.
If the machinery is not upgraded, but AI can standardize the output to some extent.
Absolutely, absolutely. And actually, a project we are working here with Philips on ultrasound is what we, instead of scanning for a long time, what we will do is few acquisitions. And AI will do all the anatomic localization, annotation, and quantitation. Currently, ultrasound takes about 30 to 45 minutes per patient. We were thinking, and you required expertise, we were thinking if we just can standardize acquisition piece and then use AI to do a lot of annotation, which technologists have to do it. So how this has to, if for AI to be successful in healthcare, you certainly need to have a cloud-based platform and the tools on the cloud, which is fully integrated in the health system. So one can really deploy this easily and it is across the enterprise anywhere. You can really use them. A lot of automation is built in for solutions where we need AI tools, and that's the model we are building for UW Medicine. Um, we will have a soon a institute of AI. It's called Institute of Medical Data Science, which is not just with from School of Medicine, but actually College of Engineering, public health and biostatistics, we are partnering to launch an institute, and I think it'll be a really a great feature for the university. And a lot of you will have opportunity to work and do research. And if you have projects or interests, kindly reach out to me. But also it has to be fully integrated. Very easy looking at the entire loop on the healthcare side. There are a lot of things we still need to do. This is just an example how AI should look like for healthcare. So there are, of course, risk associated with AI. There are a lot of perception issues. You can imagine many are worried about losing their jobs. I remember about a decade ago, there was a statement made that we should stop training radiologists because AI will take all their jobs. And actually, if you notice, I showed you we will be short 35,000 radiologists by 2034. So clearly, that is not the case. AI is not going to replace, but AI will take over some of the mundane tasks. It will augment role of physician. So very desirable because we are doing so many mundane tasks right now. So where does AI fit in? I think it's an exciting space to really launch some digital health solutions. We are already seeing progress, as I shared with you. The pace of innovation is really pretty fast, and we are seeing the investment and new products and solution coming out, increased adoption. I would say a few years back, there were hardly any health system or a radiology department using AI to make decision in prospectively. Most were doing some research, retrospective analysis. Right now, I would say almost every health system in United States has some form of AI they are using either for operation or for decision making. uh, I think this has a potential to change healthcare profoundly. As I mentioned, some areas are the opportunistic screening is so unique, and you cannot do this without automation and AI. The precision diagnosis is just amazing, and triage area. And but we need more investment in infrastructure. But as we launch AI, we need to take into consideration certain perspective, patient's perspective, what they want. you know so building a tool based on what patients need, what are providers perspective. If we may build tools which is adding extra works for provider, that's not going to succeed at all. So their perspective, what does the governance looks like for this, the technology platform, how much security there exists, and the validation to ensure these tools work across for patient demographics and countries. There are a lot of regulatory considerations that we still don't know yet, but FDA has made and a lot of progress on that. NIH is collaborating, and many societies are collaborating with FDA, and they want to make the process much easier. With that, I want to thank you all for your kind attention, and I'm happy to take any questions.
Thank you so much. Yeah, so feel free to ask any questions of Dushyant in the topics. There's a question on Zoom. Is there any data to describe the improvement of AI diagnosis over human diagnosis?
Oh, a lot of that actually. I'll give you examples of like pulmonary embolism, for example. When you are suspecting pulmonary embolism and the test is targeted for that, let's you get a history. I'm suspecting pulmonary embolism, so we do a exam which is called CT pulmonary angiogram. It's a dedicated exam. Their yield is very high. So AI might still pick few small PEs, which pulmonary embolism, which were missed by radiologists, but generally not too high. But in patients where you are not suspecting pulmonary embolism, which is 1% of patients, so out of 1,000, you will have at least 10 patients will have pulmonary embolism. So that is where AI is doing better than when it's unsuspected finding, unsuspected fractures. AI is doing a great job there. So clearly, it will assist in these areas where you were not suspecting. I was on call this weekend. There was a patient with, for cancer patient, we were looking to restage. So of course, I'm not suspecting a small pulmonary embolism. And then I look at the widget, it shows me that this patient has a subsegmental, a small pulmonary embolism. And I looked at images with more detail and clearly it was there. I would have missed it. Even with a lot of expertise and focus on cancer, I would have missed that small pulmonary embolism. So that is one such example, but in many areas, in the hemorrhage example I showed you, the AI was doing better than. It's all the subtle cases. Obvious cases, not a problem, but subtle or unsuspected cases, AI is doing better. And it's a matter of time. As you train AI more with data, AI will get better and better with those.
So pulmonary embolism for engineers here.
Yeah.
Means
It's a clot in the pulmonary arteries. So the clot, if you don't treat the clot, it can, if depending on the size of the clot, it can either lead to permanent damage to that lung forever, or it can cause enough pressure in the pulmonary arteries that it damages the heart. Patient die. If you have heard about stories, someone had a long flight and had died after that. Generally, anyone after a long flight where you have to sit, where the blood may clot in the legs, and they throws a clot which goes in the pulmonary artery, that form of sudden death, patient have acute chest pain, that's due to pulmonary embolism. So it can have consequences. Small pulmonary embolism leads to damage of the lung, um, and larger embolus can have impact to the heart. So it's a life-threatening condition. Similarly, if you have a clot in the brain, of course, patient will present with symptoms quickly, but sometimes it's not easy to recognize where it is. And the treatment, which is thrombolysis, that means you put a catheter right in the, go to specifically to those arteries, and bust the clot through some drugs directly. That requires a accurate diagnosis because this is an invasive procedure and has morbidity. So you would not like to do it in every patient. So that timeliness of diagnosis is critical. In breast cancer and mammography, we know a small cancer can be missed. AI is doing a very good job, and over time with more data and learning in detecting those cancers. So a lot of progress in AI, very exciting space. Yeah.
so follow-up question to that is in cases where you cannot detect AI really helps. In cases where you can actually detect, can you say it speeds up the time spent across multiple imaging of patient on a typical working day?
Exactly. I think in the acute setting where you want a faster workflow and reducing the length of stay. And what you need in the ED is the negative exams fast. So you can send those patients home, those who have no diagnosis of a hemorrhage or pulmonary embolism or a fracture. So I think there we can prioritize those
So the
exams.
annotations are already done
Yeah.
in front of you. You save time annotating
Yeah.
all that.
So, for example, let's say if I see a pulmonary embolism on the list where I see many positive findings, I'm in the ED. What I can do is look at the case. I take that example and send a communication directly to physician. Hey, this patient, I'm fixing the report. The patient has a PE,
Oh, okay.
in this location. They don't need each and every detail.
Right.
They needed that diagnosis so they can start managing the patient. Or this patient has no PE. You can send this patient home. So the communication can really be automated also. Like actually, right now we are working on a tool which will automate the entire communication from the detection to the team. If there is a positive pulmonary embolism, a radiologist, an interventional physician, as well as a cardiologist
So
will
you
get
have
to.
some rules that if this is triggered, then send an email.
Yeah.
Or
Yeah.
and set it up.
Yeah, and you can see this on an app on the phone and all that with an image of that, and you can communicate with the team on that. Yeah. So it's clearly, transforming care delivery. But highly desirable actually. The physicians like neurologists and all, they already used AI tools for not only stroke diagnosis, but quantifying the risk of that patient and what is the likelihood they would have a better outcome after thrombolysis, because these are expensive and really invasive procedures. So they rely on those tools now in decision making. Yeah. So these focused health solutions are very popular right now. Stroke management, pulmonary embolism management, aneurysm detection. Aneurysm is a vessel, if it grows bigger in size, there is a risk of rupture. And especially if it is in the brain, it can lead to devastating consequences. So detecting them earlier, then it changes the management, like blood pressure management, hypertension, all that.
So what you're saying is the role of AI in specifically in a hospital is not just, okay, I detected something, but what do you do before, after, and like make it end to end. That kind of solution is already being implemented at medicine in some departments.
Yeah.
And for all departments.
I think Epic has some tools, for example, where you can apply in certain areas AI. So I think it's a matter of time. You will see early adopters.
So radiology is ahead because of medical.
Radiology is so data rich and technology intense.
Right.
We have always, embraced voice recognition, PACS, name it. The digital revolution arrived in radiology way before any branch of medicine. So, yeah, you had your hand.
Yeah. So people are usually pretty private about their personal health data. Have you noticed backlash from either providers or patients about using the data?
I think most of the data is anonymized, and most of the data stays within the health system. So the model, we are bringing the models within the health system, then sending data outside. So data doesn't leave, and if anything, it's anonymized. Patients are very supportive of research. So we are not selling the data. They don't want to monetize their data, and they want to make sure there are enough safety, security measures in place to protect that. And I think as it is, healthcare data, the HIPAA, and every other rules which are in place, really we have been diligent about, and there are guardrails with the data. Our philosophy has been that we need to advance this space because future patients will benefit. But with the ground rules, making sure that you're not selling the data, and not you can collaborate with partners like with Microsoft we have partnership, with Amazon we are fostering a partnership because they have the Azure platform will be great. They are building that for all the AI work. So I think those partnerships are critical. Without that, you can't advance care delivery, and the cost will be prohibitive if you have to do everything yourself. Like with this company who we have partnered and deployed commercially their tools, that those will exist, but with under the guardrails of protecting patient data. Yeah, I think giving patient confidence is critical. Most patients have been very supportive of research.
Try to stick together questions, a bunch of disparate thoughts here. So, I'm kind of wondering about the upfront accessibility and cost. I imagine that could be a downstream version of this. The hardware becomes much more affordable. There's a lot more focus on preventative care and diagnosis. An hour, there's so much unutilized data where it's people usually go in, they have a problem, they get imaging done, somebody looks for a specific issue, but what about anything else that goes with that? Right? So it seems like this gives an opportunity to shift to much more preventive care, which then subsequently probably less cost spent on emergency procedures and that kind of thing, less money spent on doctors having to work late hours doing paperwork. I guess I'm seeing so many good opportunities. Where the challenge is, the insurance companies not want it for some reason, or is this just everybody's on board and we're driving to the board?
I think everyone is on board that AI will have a big role to play in healthcare. Everyone is board on that. I think there are areas we have not clearly defined how we will use it. So that's why building experience over time is where everyone is, most health systems are taking that approach. Take a high value low risk, high reward indication and build your experience there, the cost can easily be justified. Because, for example, the pulmonary embolism example I gave you, or hemorrhage example, if you miss one of those cases, the cost of delayed care can run in thousands of dollars or even hundreds of thousands of dollars. Whereas the software for many different applications, annual subscription for that is $100,000, which will process over 100,000 CT exams. As I told you, 1% of those will have pulmonary embolism, which could have been potentially. So you can easily justify that, and the efficiency you gain with ED workflow. If you can reduce the length of stay by 10 minutes per patient, that alone can justify a lot of expense. So there is a lot of wastage in healthcare. So if you reduce those wastage, that itself justifies it. Second, I would say is there are huge shortages from a skilled workforce in healthcare, physician, nursing staff, name it. So if you can take away some of that mundane task away and automate that, it's a highly desirable goal, because some of these jobs are not high paying jobs, so many don't want to take those jobs. So like home monitoring system, a lot of startups working on that. Wearables and managing health, lot of working on those areas. The cost is pretty minimal, if anything. I think in the long run, it will all be how we validate that data with better health outcomes results. Make sure that we have gained enough acceptance from everyone, patients, and all that. And that will be a real game changer for AI in healthcare. But the direction, the trajectory is just moving forward full steam. It's a matter of time. I've seen in last 2 years, I've seen so much progress in healthcare tools, AI tools.
What I'm sure there's more questions, but I just have one more question. Is you usually think of preventative approaches as like through wearables. We discussed that in class as well. But what you're saying is it's not just before you get to ER, but even when you get to ER or is where it's like a matter of minutes that can escalate the cost by thousands of dollars.
Yeah.
You're seeing that on a day-to-day basis.
Stroke, for example, if you delay by a few minutes, the patient's outcome will be impacted and could have devastating morbidity.
Time.
Time.
Yeah. How much time it takes for it?
Yeah, because same treatment, which is equally expensive, will not be as effective. And patient, one of the cause of disability, the leading cause of disability is stroke, which is huge expense. Anyone who has a loved one with stroke, and, the disability that causes a tremendous challenge. So our goal is to prevent that as much as possible, and these patients will get imaged, and we want to prioritize them fast to whether they should be treated or not. And not everyone has expertise to treat them, so you have to be highly selective. Same the example I told you about transplant. You have limited grafts. You need to be very prescriptive who should get those grafts. Yeah.
I'm just thinking, how many course courses would be there for
So initially, this is with the AI tool you're saying? Yeah, I think initially there were false positives initially when the tool was just launched. But over time, we gave feedback to, there is a option on the widget. Let's say you say there is an option of feedback, and you can say true positive or false positive, and you can give a comment, and it trains itself. And we have a meeting, just because we also have a research collaboration. We have a meeting twice a month with the team, so we give our feedback to them as well. So the tools will get better. So overall, false positives are pretty low. And generally they are true positive. I think it's close to 98% or so accuracy so far. And it's small, big hemorrhage, no one cares. I mean, those even a technologist will detect it right away, but the subtle ones, small ones.
Can you speak? Oh yeah, sure. Another one would be so you have a CT machine, and then the new version comes. You have a lot of data that is collected from the previous CT machine. Would it be directly usable for the new one?
That's a great question, actually, and this is where the AI learns over time. And there are tools now in the EHR in Epic for certain diagnosis. It looks at all the patients in our, not only just in our medical records, but also in every health system which is linked with Epic. What was the potential diagnosis and outcome, and which treatment worked best for those cases? So that's the one benefit of EHR, is the collaboration element and data sharing element. That's the direction currently AI is taking, is to train with other data as well. Yeah, that's the exciting area.
So you say that between different scanners, like the river and artifacts being produced in the image could change just because it's a different scanner.
Yes, I think so. Let's take CT scan for example. The CT scan is a X-ray based computed technology. So we send out X-rays across patient's body. These X-rays will interact with various body materials like bones, soft tissues, name it. And then based on the attenuation profile, we get a sinogram, and that is then prescribed into a grayscale image. Now, that is dependent heavily on the scan parameters you are using, because it's a complete 360 projection that requires more X-rays. That leads to higher radiation dose. So now with AI, and if you reduce the X-rays, amount of X-rays you are giving to the patient, it will impact image quality. And that was one of the reasons why we could not reduce radiation dose, and there was so much concern related to radiation from CT scanners. But now with AI tools, even with less X-rays, the AI learns how the projections would be, what should be the tissue texture like based on the initial scout, which is the initial sinogram, the topogram image which is taken, which is like an X-ray, digital X-ray. It gets an idea of the composition of the tissue and how much X-ray should be given, and then it makes some assumptions what it should look like. So radiation dose has dropped to a fraction for many indications, especially in vulnerable population like young kids. Now you can get it at a fraction of radiation dose due to AI. And it gives
Medicine or
UW Medicine. Most of our scanners have some smart technology. MRI, same thing. Now, one reason MRI takes longer is because the process takes long. Otherwise, the image quality will not meet the diagnostic expectations. So now with AI, there are startups and all where you have to do limited sampling, and it fills the case space completely and gives a high quality images similar to what a regular.
those are trustworthy.
Yeah.
For
Yeah.
radiology.
Yeah. Give you an example on a PET CT. PET CT is a study which is used in oncology. We give a tracer intravenously. This tracer has a glucose in it, and this is taken up by areas which have high metabolism. It's taken by all tissues, but those areas which have high metabolism, like tumors or inflammation, will have higher uptake of that. Now, the FDG, that tracer or dye for is expensive, and also it adds some radiation dose. But you need that much for the image quality. Now with AI, you can really extrapolate from the limited data and create an image which is subjective to have the contrast and quality for making a diagnosis. So clearly you cut down the cost of a dye, but also overall scan time, how much you need to scan. I showed you that it takes about 60 minutes per whole body PET CT scanning for cancer. If you can drop that by 50%, of course, you increase patient access, you double it, you improve your bottom line, you reduce the cost. So certainly AI is helping with some of those goals. So very exciting in that. Yeah.
So one of the questions I had kind of relates to the potential conflict between cost optimization and patient optimization. Something we've seen a lot in the U.S., specifically the private clinicians really feel that when they're trying to do what's best for the patient, they feel like privatized insurance is kind of fighting. Do you see even already some examples of that in terms of applying AI?
Yeah, I think there is some truth to it why insurance companies are, creating some barriers. They want to make sure that there is more appropriate utilization of some of the either treatments or tests, expensive, especially high value tests. So therefore, the insurance companies will approve it readily if you are using some clinical decision support tools, because those are based on indication and appropriateness of the exam. Same as for treatment, AI might enable that, where insurance companies more likely to support those treatments. In long run, insurance company will save more money because AI will show you that most of these fancy treatment will not give you any better outcome than what you will get it with these currently available conventional or standard of care therapies right now. So if not the insurance company, the pharmaceutical companies will be more worried about that. They are the barriers, not the insurance company. Insurance company want to actually support these things. Insurance companies are very excited about using AI and tools to select patient who will benefit most because they want the best outcomes for those patients. And right now, I would say 20 to 30%, maybe it's a conservative estimate, of healthcare dollars are complete waste. That's why insurance companies are so concerned.
So you spoke about physician burnout, 50% statistic. Do you see with the increased use of AI, this is a philosophical question, you have less physician burnout, or will it be that you're able to do more, but you still have to take care of burnout?
That's a $1 million question, and I don't know how to answer that. In general, my belief is all big companies and healthcare systems, they recognize that they have to value their more treasured resource, which is people. And and to do that, they will have to make their job more enjoyable. And to do, we will have to introduce those tools, solutions to make their professional lives more productive and meaningful. My hope is that these things will make, you know, physicians and healthcare workers' life slightly better, or maybe empower them with better decision making. Hopefully, but you'd never know what other things will get added on. Like with all the improvements in AI tools. If let's say take an example, if there is a case of lung cancer that I'm restaging or staging, first of all, I give all the staging. Then I have the tumor information, what is the radiomics information, all that. So I added that. Then I give a body composition information. Then I saw incidental finding and I have to give recommendation. I don't think so it'll be enjoyable for me. Because I'm now thinking, I have no idea what is going on with this patient. So clearly we will have to see what are the real valuable indication where AI should be applied and which areas we might have to just scale back. For example, the radiomics one might be best applied after the fact before we are looking for treatment, not at the time of initial diagnosis.
So we also have a module in class on interpretability in AI. Like, do you encounter issues in practice where AI says this is true of this image, or you look at this, the physician is like, I'm not seeing it, or it's not obvious to me. Like the imaging part that you showed is probably make out, but are there cases that you wonder how exactly did it figure it out?
Yeah, absolutely. I think the cases I showed you are very high contrast cases. you have black and white type of, or some strong grayscale distribution you can recognize. Whenever those differences are less, um, or there is similarity between a normal finding and abnormal finding, I think AI makes mistakes, unless the it's deep learning, then it get better. So it depends on the model and
But the deep learning we can't explain.
Yeah,
We can't tell you why
yeah.
exactly. So is that an issue, like not being able to explain? Because physicians like to explain.
Absolutely. Physician needs evidence. Without that, so I'll give you an example on the kidney stone side. There were calcifications in the body, surgical clips which were close to the ureter or kidneys, and AI was picking all those things. Then once we defined the outline of the kidneys well and trained AI which is kidney, which is not kidney, then we also made sure AI learned on prone and supine, because some patient we scan prone for kidney stone, they are lying on their belly to see if the stone is in the bladder or it's attached to distal part of ureter. Because if it is in the bladder, then we don't intervene, that will pass off. And if the stone is in the distal ureter, but at the junction of the bladder, urinary bladder, those stones might need intervention or a follow-up. So for that, we do a prone exam. So because it's against gravity. So in that case, we train AI models both in prone and supine, because the anatomy changes in prone and supine. So AI was making a mistake for that.
Related to that question, has there been any work done to maybe discover new markers for condition based on this sort of like some crazy deep learning thing, where like how did it come up with that, and then you dig deep and you find some pattern that would work for it?
I think there is a published data in oncology space where people discovered things which they had no idea about those through AI work. And like the opportunistic screening is one area we are learning so much about patients' risk through, let's for example, hepatic steatosis, which is fat deposition in the liver, which is happens due to many reasons, have very strong correlation with certain patient with very low microbiome diversity, fatty liver. So in the right patient, which we had no idea, we didn't know why should be there a link between fatty liver and microbiome diversity. Now in the right setting, once that happens, there are, you do stool test and maybe colonoscopy depending on the type of patient. So I think AI will uncover so much more from the data, which is overwhelming these days, and we don't have a way to make sense of the data. Um, on any given day, if I have to go through a patient's medical chart while rendering a diagnosis, sometimes it takes me 15 to 20 minutes just to go through a simple thing, sometimes more than an hour to find out. Let's say I pick something in the pelvis and I don't know if patient had a prior surgery, and this is a surgical defect which is expected versus a patient who might have a problem here. So not everything is listed in the recent history. So I have to dig through the entire medical data set. AI can do that for me. AI, if I'm in that region, if I put a cursor and a right click, it'll give me a relevant history for that. Yeah, prostate TERP in 1989 or something. So all that will make job easier. So, and it's getting there. It'll take some time, but a lot of progress. Yeah, I think the wearables is a bigger market, and IT company don't have to go through the hospitals and physicians. They can go directly to patients, so it's much easier. A lot of that data exists on the cloud to begin with. So if we sign some kind of agreement that they can use our data for research many times. So that's much easier to validate and build tools faster because you have less regulation and bureaucracy, whereas doing anything through healthcare has much more scrutiny, higher cost, and much takes longer to do it. That's why. Yes. But for specific things like, when to trigger patient has arrhythmia and all those tools will come out. Already they are out. Now Apple it tells you if your rhythm is abnormal and alert. So that's already there. So it's a big deal, you know. Karthik and I were chatting that if, wellness, we both believe strongly in personal wellness through meditation, breath work. And we were thinking if there is an app which senses your temperature, pulse, and a little bit based on your muscle contraction if you are stressed or not, and triggers certain things like a wellness activity you should do it, like guides you based on that. Will be a huge market for that, because mindfulness is so popular right now. It's mainstream. One of the hardest discussion right now is mindfulness and wellness part of it. So you can imagine that is much easier and better and a bigger global market for that. Everyone has some, not everyone. Most either they have a smartphone or a watch. A digital watch has some tools available to apply. So for that reason, it's a more attractive, and a lot of startups are focusing on wearables. And eventually, it will find a role in the EHR. Finally, it will get there. It's all about validation, you know. Yeah.
So yeah, about the stress, my ticket shows I'm stressed. I don't know how it's active this thing. So that's really so all this needs to be clear to FDA in order to be used in the hospitals, right?
Yeah.
Is there much time difference between a solution that does not use AI going to the FDA and something that uses the AI? Because I don't know, like usually like courts and all, judges take so much time to catch up
Yeah.
with what is happening right now with baking and all that hearings we have seen there.
Mhm.
Is there such a problem for all this AI devices?
That's a great question because depends on what is that AI tool for. If it is for detection, not diagnosis, the process is faster. If it is for workflow, it's much faster. It doesn't require because the risk is extremely low. It all comes down to risk. If you say that this tool is for diagnosis, that will require much stringent FDA evaluation and longer timeline. So you will rarely see a tool which says diagnosis. It all will say detection, computer aided detection, not diagnosis. Yeah.
So follow up to that is even for as an IT solution, we piloted or tested hospitals that we
Yes, if you're applying it, so all the image processing, 3D,
right,
is the same concept.
right.
It's a computing. Advanced AI, personally, to me, is advanced computing, no different. So all the image processing tool require FDA approval if you are using it, and especially if you are billing for it, you definitely need FDA approval. So those have relatively low bar for approval. Anything. So AI tools are seen in the same way as image processing tools. But about integrated diagnosis, precision diagnosis, all of that will requires much more data and stringent evaluation for that.
Yeah, I have read that this Google smartwatch that Fitbit is associated with Google, and they are rolling out a new feature for finding BP, but then it is not FDA clear. There's a disclaimer: do not be used for diagnosis. Yeah, it makes sense why they have
Yeah.
done that.
It's always once it's for diagnosis, it requires much more, and it also comes down to your reference. What are you using as a reference? If you have a low standard which is already approved many years back, it's easy to get it approved. Then the reference is so weak. So
Question. That's one question. But
On the
That's detection.
Yeah, so diagnosis is you are making a diagnosis. This is on annotation, segmentation. That's easier. It's like image processing. So that is not you make a diagnosis. If the AI creates something where someone acts on the AI alert only without a proper physician interpretation, that will be considered a diagnosis. Yeah. Yeah. So that is so far most of our computer aided detection, not diagnosis.
But if a physician quickly looks over the AI presented diagnosis and then makes a diagnosis,
No one monitors if physician has even looked at the images or not, or a lab test. So you assume a risk. It doesn't matter what you use. I might have asked a colleague, hey, look at this exam and tell me if it is. So even though it's not my interpretation, but still I can bill for and get paid for it. So I have assumed all the risk there.
yeah, yeah.
So there is no risk for the computer. Yeah.
So in the field of oncology, like and cancer, like do you think variables will play a role? Maybe not now, but in the future, because cancer is not a slow building disease, happens over months or years. So before people get to where they are, see some.
I mean, there is, I'm not an expert there, but what I've heard from scientists working in the space, um, they feel that some of the genetic materials that is either excreted in sweat um, or other body fluids and all that, they can potentially test for any DNA strands or RNA to test if patient has tumor recurrence because they will be shedding in the blood, some of the DNA. So, but I don't know how the cancer recurrence can be monitored just through that because early detection is the key. So there is a lot of it.
First time detection.
I think first time detection, if by the time variables will show, it'll be too advanced. What will be factors if variables can show?
That will
us?
be more advanced
Yeah.
sensors than
Yeah.
heart rate and
Yeah. People are actually looking at more like a urine test and seeing if there are some DNA or some changes they can detect with some urine test kits and all that which are being developed. Uh, some are even working on testing the breath for lung cancer and seeing if you can monitor through that. But I haven't seen any meaningful progress there. But
So I think for background, most of us know like AI model that will do some prediction for you. How do the say we come up with something like as per COVID how does the hospital or whoever's the decision maker decide what's the bar for acceptability?
so for clinical decision making, the bar is FDA approval for a lot of that. You can still make decision but have some idea about what the tool is saying. That is acceptable. But to make it fully integrated in decision making, where across the health enterprise, any physician can make a decision, the bar is very high. You need to really validate in different types of patient, different viral load burden, different types of lung infections, body types, race, ethnicity, sex, name it, risk factors. So, yeah, I think to build that tool, you'll need validation for that. But if you have an idea, you can propose an idea and see if there is already a lot of data, curated data available. Like in radiology, what we are doing is we are curating the database of few cancer, like lung cancer, colorectal cancer, liver cancer, prostate, and breast cancer. I think those are the 5 or 6 ones. Now that data can be interrogated with different tools. So it makes the validation of AI or new algorithms bit easier. So if you have an idea, you should you know share it or discuss it with someone who is expert in that space, like infectious disease, or someone who does build predictive models, or like someone in the uh, uh, population health.
So I guess, you know, in the presentation, they have like a benchmark every year.
Yeah.
I'm sure there's this, but it doesn't automatically become a product.
You know what, it becomes a product by giving a probability scoring. Like, for example, if you can quantify things in body based on images, you can give a probability scoring. This is probably so much likelihood of COVID or an infection. That's possible. Uh, we use a lot of tools to quantify stiffness in the liver, MRI based tools or ultrasound based tools to assess how bad is fibrosis or how stiff is the liver, which has a correlation with outcome in the patient and how soon patient might need transplant. What is their functional reserve in the liver. Normally, you have to biopsy, and you know that a lot of these conditions are not static, they are progressing. So you biopsy now, 3 years from now, it will be totally different. You can't keep biopsying. You need a non invasive biomarker to assess from baseline how much has it changed over time. What is the either progression or stability improvement? If there are treatments you give for chronic liver disease, then you say, okay, it's actually stiffness has gotten better. You can't biopsy every time. So for those, the tools will give you a probability scoring, but it has to be validated against a reference standard, which will be biopsy in this case. Same for that, you will have a conventional CT scanner where radiologists have graded it, interpreted it using a more structured language, um, and then you will have to validate that against a patient's diagnosis.
I think for now, we should join startups that are having tie-ups with hospitals so that whatever you do, they get into that solutions.
The real opportunity is in area of either improving workflow. I think because the bar is lower for approval and the impact is huge. And operations or workflow in healthcare is right now the high priority globally to improve access, lower cost, improve bottom line, everything. So there is tremendous focus on efficiency and workflow. So tools related to that are great. Also, tools which can help with personalized medicine in few specific indications, will be great. And the third one will be more on the population health side, looking at risk predictions and all that based on certain findings, likelihood of this patient needing lung transplant based on how bad is the lung right now, whether they need if everything goes as projected, if patient doesn't change their lifestyle or behavior modification, then in 5 years they will need lung transplant. And if you do this, patient might need in 20 years. So that kind of, and what is the ramification to cost? Insurance company pay for those type of tools. Already we pay for a lot of these things because there are private softwares with using AI for quantitation. We pay for those things. But it's a huge space. There is a lot of opportunity.
I think it's 5:40, and really enjoyed the talk.